So we got quite a few folks on. Why don't we go ahead and get started? We've got some good cases for you guys this morning. So now you third years are kind of getting close to graduation and getting close to the board. So you need to make sure you feel really comfortable with derm path so you don't have to have any problems when you get in there. So somebody want to give this one a go?
Yeah, I can take this one, Dr. Cockerell.
Great.
So just from low power, it looks like we have a punch. It appears that there's, just from this view, like some pseudoepitheliomatous like hyperplasia, some hyperkeratosis seems to be ortho, and more of like a superficial inflammatory infiltrate.
Good. Now, why did you instantly go to pseudoepitheliomatous hyperplasia?
It's pretty striking. It's kind of the first thing I noticed.
Could you have possibly thought of maybe a squamous cell carcinoma?
You can actually, without seeing kind of this, like, the atypia or anything like that, I wouldn't rule it out yet.
Yeah, one of the points about this is they did a really nice biopsy. They took a punch, obviously, so they got it into the dermis and the fats. We could see that. But if they just would have taken a shaved biopsy through here and submitted it as rule out squamous cell, you could very easily call this a squamous cell carcinoma. It's got some, dyskeratotic cells here. Some of these cells are a bit large, pleomorphic. So I think one of the teaching points of this slide is that, you got to be careful of this sort of pattern. If you don't take a good biopsy like this, it gets a representative sample that gets beneath that. I've seen shaved biopsies of the pseudoepitheliomatous hyperplasia overlying infections get called neoplasms. I've seen granular cell tumor shaved. The PCH over that gets called cancer. So you just have to be careful when you're dealing with a verrucous crusted lesion. If you take a shave, make sure you don't just go into the epithelial component. Make sure you kind of saucerize down deep. So if there's something beneath here, you'll pick that up. So here, yeah, you're right. It is pseudoepitheliomatous. So what's causing the pseudoepitheliomatous hyperplasia? Is that the diagnosis, or is there some other process that's leading to this?
Yeah, so it's usually a finding of something else that's kind of causing it. In this case, it can be a couple different things. I was trying to figure out what it would be in this case. I know, like in granuloma fissuratum, like depending on the right clinical location, sometimes you can find that here, if like rubbing from like some like eyeglasses. Sometimes you'll see it in like infections. So I know like chromoblastomycosis can have it, but I didn't see any of the copper penny spores.
Yeah, and when you're dealing with those kind of things, really, you'll see a suppurative granulomatous inflammation in the dermis, and then you get the secondary pseudoepitheliomatous hyperplasia overlying it. And what's all actually happening in those situations, in many cases, is that the host is trying to transepidermally eliminate the process, right through the epidermis. So that's kind of why you get those abscesses that form, and you see the little channels that get formed in the epidermis. So it's a reaction to the underlying organism. It's another way that the host tries to deal with those sort of things. Sometimes foreign bodies also, like you'll see somebody that maybe has maybe they had an auto accident and got glass and something in their skin. They get a secondary granulomatous inflammation and pseudocarcinomatous hyperplasia overlying that. But this one's more subtle here. You don't see any of those things.
Yeah.
So what else could possibly do it here? I'm trying to show an area here that might give you kind of a clue. So this is a relatively hard biopsy. You really see mostly pseudocarcinomatous hyperplasia. Can you see what I'm pointing out here? What's going on right here in this focus right here?
So right on like the interface, they're not exactly sure in particular.
See these holes right here?
Yeah.
It's vacuolar alteration at the dermal junction. So it's an interface dermatitis. And if you look in another couple of areas here, we might even see some thickening of the basal membrane zone, like right here.
Oh, yeah. Okay.
So this is relatively subtle. Most of the time when we see this process, you usually see a superficial and deep, denser infiltrate. But we do have these areas here, which represent follicular plugging.
Yeah. I think, yeah, I know what you're getting at.
Yeah, so now you can read my mind what I'm trying to get you to say. So what's the diagnosis here?
Discoid lupus.
Yeah, and this is an example of so-called verrucous lupus erythematosus. Most of the time when we see this, and this was a little bit odd, but we don't see this very frequently, so I just wanted you guys to kind of at least have a chance to be exposed to it. Usually you'll see a superficial and deep infiltrate, not just a sparse, interface dermatitis like here. It's usually much denser inflammation. But this guy had known lupus erythematosus. They biopsied this lesion to rule out what they thought might have been a carcinoma developing in the areas of LE. And lo and behold, it showed this, which is just an example of a verrucous lesion of discoid LE. I've seen this missed many, many times when clinicians take a shave biopsy of this. I've seen this called squamous cell carcinoma. There actually is kind of a famous case from probably about 50 some odd years ago here in Dallas of a lady that had discoid LE on her nose. Shave biopsy was performed. It got called squamous cell carcinoma. They did wide, excision, Mohs, all that kind of stuff. And then the whole thing just kind of totally broke down because it was really an inflammatory process that was causing the epithelial hyperplasia, and ended up in a lawsuit. And so basically just beware of this. Beware of the business of taking shave biopsies of pseudocarcinomas hyperplasia. If it doesn't make sense, if you don't really think it's a cancer and it comes back as a cancer, pull back. Don't just instantly go to surgery. There's another case I show in a lecture I give many times. It shows an individual that had a biopsy of pseudocarcinomas hyperplasia of the ear that was due to leishmaniasis, and they got their whole pinna removed, everything because it was misdiagnosed as a squamous cell. There's a famous case here also of a patient that had pemphigus vegetans, a woman. They diagnosed her as having cancer. She had a cervical, they call it cervical cancer. She actually had pemphigus of her cervix, and they actually did a hysterectomy. She was a young woman, never had kids anymore. So just beware of overcalling things too. So we always think that we don't want to undercall stuff, but you can overcall things too, and that can be a problem. So this is an example of so-called verrucous lupus erythematosus. So just remember that's yet another thing that can give you pseudocarcinomas hyperplasia.
Okay, great case. Thank you.
You bet. Okay, this is kind of an interesting case here too. This is not quite as good as I'd hope, but at least I think it shows some of the changes over here. Anybody want to give this one a go?
I can take this one.
It's pretty boring, but it's got some educational purpose to it.
So it looks like either an excision or an enucleation.
Good.
I think it's in the lipoma category because there's a lot of adipocytes.
Good.
And then in between the fat cells, I think that's most likely fibrous tissue. At first I was thinking trapped skeletal muscle, but I think that's just fibrous tissue. I'm not seeing a lot of vessels. There are a couple of vessels that might have some thrombi in them. I'm not seeing any like pleomorphic cells, giant cells, atypia, or mitoses. So I think one of the things I was thinking is if that is skeletal muscle, it could be an infiltrating lipoma, but I don't think so. So other thought is maybe an angiolipoma, but there's not a lot of vascular proliferation. So to me, I'm not sure what if there was anything here I was missing, but to me it just looks like a pretty classic lipoma.
Well, basically you're going down the right pathway, because basically what you're doing is kind of listing some of the different subtypes of lipomas, and there are probably about 5 or 6 different types. There's the garden variety lipoma, just common lipoma. Sometimes that can be associated with in the conjunctiva. There's a thing called Goldenhar syndrome that can be associated with the lipoma of the conjunctiva. So just remember that. If you see one that kind of looks like a little marble in the skin, maybe 2 or 3 little sort of well circumscribed little lobules, think of so-called mobile encapsulated lipoma. That's yet another variant. If you see the blood vessels that you described at the periphery, that almost looks like almost like an angioma, if you will, within the lesion. It doesn't look exactly like an angioma. The blood vessels often have the erythrocytes are kind of sludged in there. They're not really usually thrombosed, but you get the sludging of the erythrocytes. And sometimes that vascular component can be the majority of the lipoma. You can have 80% of it can be vascular, and just a little bit of it can be the residual lipoma. So that's obviously an angiolipoma. You mentioned pleomorphic lipoma. There's also, and you get those large floret cells that kind of look almost like lipoblasts. So you want to make sure that you don't confuse that with a liposarcoma. And then there's the myxoid lipoma, where you get a lot of mucin in there, spindle cell lipoma, which get a lot of cells that have a spindle cell morphology. That's sort of an overlap with the myxoid lipoma. And then there's this variant called a fibrolipoma. And you're right, you did identify these large aggregations of fibroblasts and collagen sitting in here. It's just yet another variant of a lipoma, sort of not really super important, but just to recognize it as yet another one of the lipoma variants. I don't think they would show you this on the board because it's so boring. If they showed you something, they might show you something like a pleomorphic lipoma or an angiolipoma, or they might show you a combination of an angiolipoma with some areas that almost look like smooth muscle involvement, and they might say this is a angiomyolipoma, and what disease, what syndrome is that associated with? I'm sure you know the answer to that.
Oh, I actually don't.
Tuberous sclerosis, you get renal angiomyolipoma. So not usually in the skin, but if we see it in the skin, which we don't very commonly at all, rarely, we'll at least mention that it's associated with tuberous sclerosis and just make sure that the diagnosis hasn't been missed. But just basically, this is just one example of the many different subtypes of lipomas. And when you're looking to diagnose a benign from a malignant lesion, there you're really looking for asymmetry, a lot of cellularity. You look for lipoblasts, which are primitive lipocytes that have some, pleomorphism to them. They kind of get a signet ring morphology. You really don't see any of those here. So those are just some of the things you look for when you're trying to diagnose, say, a malignant lipoma from liposarcoma from a lipoma. But that's more in the soft tissue neoplasia category. I really doubt seriously that you'll be getting that on your exam. So good. This is just another variant to kind of put in the library. I'm not sure why that's here. I kind of should go at the end. Okay, why don't we go on to the next one?
Good morning. I can do this one.
Okay, great.
Okay, so it looks like we have a punch down to the fat. Looks like there's some scale crust at the top and a very thick band of inflammation. Looks like interface dermatitis again, kind of obscures the junction between the dermis and the epidermis.
So you think these are all inflammatory cells here?
Yes.
Okay. And what kind of cells are these?
Lots and lots of histiocytes.
Okay, so you thought this was histiocytic.
Yes.
Okay, so if it's histiocytic, then what do we, when histiocytes predominate, what do we think about there?
I'd want to rule out an infection.
Okay, so infectious. What pattern of so you're thinking this is in the granulomatous category?
Correct.
What pattern of granulomatous inflammation would you call this? Is it suppurative granulomatous? Is it foreign body granuloma? Is it palisaded granuloma? Is it sarcoidal granulomatous dermatitis? Foreign body? Or none of the above?
None of those.
None of the above. Okay. So let's look at it a little higher magnification.
Mm-hmm.
Any sort of things when you start looking at it, it's always so it's a good point when you see something you say, gosh, that looks like histiocytes at low magnification. What are some of the morphology of histiocytes that we see histologically? And that's kind of a sort of an open-ended question, but when you want to look at a histiocyte, for example, can you think of some morphology that histiocytes can assume histologically? Like
the foamy kind?
Good. Foamy histiocytes. Excellent. Like a Teuton giant cell's got foam in there, maybe a foamy histiocyte of a xanthoma.
Like pleomorphic cells, does that count as a morphology?
Well, you could, sometimes histiocytes can be a little bit pleomorphic. You get multinucleated histiocytes, you can get epithelioid histiocytes. So that's kind of an important component. So I'm thinking this is the old, play the game of read my mind sort of thing. So are you aware of any kind of tumor, neoplasm, that can look like a granulomatous dermatitis. That's an important entity not to miss. It can look like granulomannulary histologically, and it's seen often in young individuals. And if you don't want to miss a diagnosis, it's one of the most common causes of sarcomas in young people on the acral parts of their body, on their arms and whatnot. You may not remember that. It's a relatively, not totally obscure thing, but it's something that I definitely want you to put in, file away in your mind there, to always think about it, at least briefly.
Like a mastocytosis or.
Well, epithelioid sarcoma is the thing I was thinking of. If you do a biopsy of something that looks like a granulomatous dermatitis, it looks like GA histologically. And then you look at it, it looks like a palisaded granuloma. What's really happening is you've got a neoplasm that's undergone a central area of necrosis, and it gives you a pseudo palisaded granulomatous process. And you look at the periphery, you can see the cells are really kind of atypical, but they look like histiocytes because they're epithelioid histiocytes. So remember, epithelioid means it looks like an epithelium. It's not really epithelium, but it looks like it. And histiocytes can also assume that morphology. Now, when you're looking at granulomatous dermatitis, is it usual to get this kind of thing going on?
No, definitely not.
It's bizarre to get this kind of ulceration and whatnot. And maybe it's dealing with something like we talked about before, a granulomatous, suppurative granulomatous dermatitis with pseudocarcinomatous hyperplasia, but this doesn't have any epithelium here really that we can see, right? It's just kind of ulcer.
Right.
And as we look at higher magnification here, can you see that these cells, they don't look totally normal, do they? I mean, you got some that are, that one's dying.
Right.
Got some that's in mitosis, that's in mitosis.
Mm-hmm.
So rather than histiocytes, is it possible this could be something simulating histiocytes?
Right. I think so.
Good, good. And let's look another area here. You got these, and this is a kind of a challenging case in a way, because it does look a lot like, in some ways, like histiocytes, like epithelioid cells, but it's got these little small spaces here, these kind of cleft-like areas here. Can you appreciate those?
Mm-hmm.
Does that give you any kind of clue when you see slit-like, cleft-like spaces in something that may be a cancer?
Yes. So there are lots of also extravasated red blood cells, and I saw some of those cells that look like they have the punched out appearance from the vacuolar degeneration. So you can think about Angiosarcoma.
Yeah. And see this off to the side here? That's kind of got the cells kind of floating freely, you know, into these probable vascular spaces over here. Yeah, this is an example of an epithelioid angiosarcoma that doesn't really look like an angiosarcoma when you first look at it. It really almost looks like either like a granulomatous process, like you said, or maybe even like a melanocytic lesion that can look epithelioid, or it can look like a squamous cell carcinoma in some cases, poorly differentiated squamous cell carcinoma. So this is an example of a lesion that's kind of simulating, it's almost kind of a wolf in sheep's clothing a little bit, because it doesn't look exactly like an angiosarcoma, but this is probably one of the most aggressive tumors that we have in dermatology. As you know, these patients do really terribly. And this is an example of necrosis en masse. It's where the cancer is dying. If you look in this area up here, sometimes you have to look really hard to find the clues, if you will. So if I just showed you this field, you might think angiosarcoma here, right? Because it's got the little slit-like spaces. It's got the atypical endothelial cells protruding into the lumen. So this one little area out of the whole thing is suggestive of angiosarcoma. The rest of it just looks epithelioid and says, wow, that it's probably a cancer, but we're not really sure which one it is. So this is just an example of kind of a situation where you get epithelioid cells giving different morphologies to things that we don't really normally think about very commonly. So just remember that this is yet another cancer that can give you an epithelioid morphology. Now, one thing I'll caution about, whenever dermatologists and soft tissue cancers come together, it's usually like a train wreck. Usually there's a problem. And so I've seen cases of angiosarcoma taken by shave technique, and it gets misdiagnosed as an ulcer, you know, so like if people take a superficial shave of something like this. They don't sample the area. So when you're dealing with a soft tissue cancer of any kind, you have to be very concerned about sampling error. These lesions are often large. They're almost like a continent. and if you biopsy France, it's going to look different than if you biopsy Italy, and so these things often have multiphasic morphologies to them. And some areas can look pretty bland. They don't really necessarily look atypical. And so if you sample, say, like a DFSP by shave technique, you might hit an area that looks myxoid and almost looks neural, and you might get back a diagnosis of a neurofibroma where the patient got a bad neoplasm. So you have to always beware. And so, yeah, they took a punch biopsy here, which was pretty good, but notice that there's only one area that shows the angiosarcoma that you really recognize it's an angiosarcoma. It's very difficult to diagnose this for sure. So I would say that if you're dealing with a funny neoplasm that looks weird, take a picture, submit it with the biopsy, realize that you may end up having to take an incisional biopsy or get them in the hands of a surgeon or something like that. But beware of taking biopsies, partial biopsies, even punches that we think are good for dermatology diagnoses of large soft tissue cancers. They often are prone to sampling error. And I've seen lots of lawsuits get sparked because of that.
Thank you.
You're welcome. Okay, now we'll move to something a little less nefarious, but important nonetheless.
Yeah, I can take this one. So this was a punch. I was thinking it may be acral skin, given the thick stratum corneum.
Is it purely palm or sole?
I'm not sure. Or I mean, it's not that thick, so maybe like the ankle or near acral skin.
Could be. It could be that. Yeah, it's definitely not pure acral skin because it's got a sebaceous gland there, right?
Right.
That's part of a hair follicle here, most likely. So, yeah, and there's a follicle over here. So unless the person is a chimpanzee or a gorilla or something, it can't be acral skin because we don't grow hair on our palms and soles. But we do grow the hair on the back of our hands and on the sole in the dorsal surface of our feet. So it could be near acral skin. So you're right about that. But saying that it's not acral skin, then maybe that's not normal cornified layer, right?
Right.
Yeah. So in other words, if it's on non-acral skin and it's got a thick cornified layer that looks kind of like acral skin, you say that's 2 + 2 = 4. It's absolutely impossible to be acral skin in a human being. So we're going to say that cornified layer is abnormal. So then we start thinking about diseases of the cornified layer, possibly, correct?
Yes.
And what about the epidermis? Is that a normal epidermis?
No, there's some areas of acantholysis.
Acantholysis or
Like acanthosis.
acanthosis? Yeah, I think there's some artifact here. That's kind
Okay.
of the
Yeah.
artifact. But I agree. I think
Definitely
it's got some
acanthosis.
acanthosis, kind of irregular acanthosis. I totally agree with that. What about the inflammatory infiltrate? Scale of 1 to 10, where are you going to put it?
I thought it was pretty sparse.
Yeah, about
Mostly
a 1.
some lymphocytes.
Minimal inflammation.
Yeah.
So this is inflammatory. It's going to be a sparse superficial perivascular dermatitis, but the main change are going on up here. So I agree with you. Main change is going up here. So let's look at that cornified layer. So what's going on with that cornified layer up here? What's this stuff?
I think there's like some parakeratosis.
Yes, there's lots of parakeratosis here. You see all these nuclei are retained in here. And there's this kind of, what else do you see besides the parakeratosis? What about this stuff up here?
Yeah, kind of some. Is that hyphae or?
No, it's not hyphae. But you see that it's also got some eosinophilic kind of characteristic of some of these keratinocytes in the parakeratotic area. And it's
Mhm.
got this dark purplish color, and we see that, we sort of think maybe there's even some dystrophic calcification going on up here.
Mm.
And it's kind of got a granular morphology to it. That ring any bells to anybody?
Yeah, I'm trying to think through. I think, hyper focused on the vessels in this one. That like in the dermis. I'm trying to think. Parakeratosis. Is this
And notice the
granular
parakeratosis.
parakeratosis?
That's exactly what it is. It's
Okay.
granular parakeratosis, which usually occurs in the axilla, but doesn't have to occur in the axilla. We see it's often seen in an area where there's some, maceration, like maybe underneath the breasts or in the groin area, that sort of thing. But if you were taking an exam, they could very well show this to you, and they would probably put some different things down in the differential diagnosis for you to choose from. So they might put psoriasis down there. So do you like psoriasis here?
Not necessarily. It doesn't really have the psoriasiform look with the acanthosis.
Yeah, it doesn't have regular acanthotic epidermis, but the cornified layer is wrong for it too, isn't it?
Right.
What's the cornified layer usually look like in psoriasis?
You can get parakeratosis.
Your parakeratosis, but what does the parakeratosis look like? Does it look like this kind of parakeratosis?
No, it would be like more diffuse or more
Mounds of parakeratosis,
yes.
mounds with neutrophils at the summits of the mounds. So remember that. Mounds, little mounds, like little mountains of
Mhm.
parakeratosis with neutrophils in them. That's psoriasis. That's a class form of psoriasis. And even if it's relatively broad parakeratosis, you'll still see neutrophils in there, and it tends to be more in mounds rather than being a diffuse confluent parakeratosis with neutrophils like you see in pityriasis lichenoides, for example. So you can tell a lot just by the cornified layer. So this has got a very classic sort of pattern that we see with this granular parakeratosis, basophilic, and this eosinophilic granular morphology of the parakeratosis that's confluent over a broad front with this kind of crusty granular stuff on the surface that's even possibly even calcified. This is very characteristic of this pattern of parakeratosis. And then so make sure you kind of bone up on the different forms. They might put this on there. They might put psoriasis. They might put erythema on there.
Mhm.
Fool you. They might put pityriasis lichenoides on there. They might put Tinea versicolor. They might put Tinea pedis or something like that. So just recognize that this type of cornified material, cornified pattern, is classic for this condition. Just very, very classic for this. So make sure you know that. They very well, this could be on your exam. This is fair game. If I were writing questions, I might put this just to see if I can fool a few people. So it's not that common, but it's something that as a dermatology graduate, you should know. And it gets misdiagnosed as psoriasis and irritant dermatitis and all sorts of things. We don't really know the cause of it. Some people think it may be related to aluminum containing deodorants, but I'm not really sure that's the case. But we do see it fairly commonly.
Thank you.
Okay. All right. Next one was pretty steady hand with this stupid thing. There we go. Okay,
I'll take this one. This is Taylor.
good.
So we have a shave, and I'm leaning towards the neoplastic category.
Good, perfect. Are you leaning towards benign or malignant?
I'm leaning towards benign. It looks
Good.
very symmetric and
Excellent.
even.
Symmetrical. What about the size?
I mean, we just have a shave, so it's hard to say the depth that it goes, but overall looks very
This whole
small.
thing's probably maybe 5 millimeters across. So the lesion itself is probably maybe about 4, at least from side to side. Yeah, we don't know how deep it goes, but seems to be, if we drew, a small lesion that's well circumscribed and symmetrical. So it's got those features of benign. I agree with you. What about epithelial? What about differentiation? Epithelial or non-epithelial?
I had a difficult time at first, but I think it's epithelial.
Okay, now what do you use to tell epithelial from non-epithelial? What kind of criteria do you use usually? So something's non-epithelial. What do those cells usually look like? What shape are they usually?
Like cuboidal.
They can be, but mostly what? Well, like here's a non-epithelial cell up here, right? That's a fibroblast. What shape is that?
It's like a spindled shape.
Yeah, they tend to be more spindly in shape. Don't have to be, but they tend to be. So if they're cuboidal or they're, kind of look like little squares, they're kind of touching and hugging one another, or they're round and they're really closely opposed to one another, tends to favor epithelial. Okay, now with the epithelial, then they say, okay, what kind of epithelium, right? So we just talked about epithelioid, where things are mimicking an epithelium. Now we're talking about real live epithelium. So we got about, maybe 4 or 5 types of epithelium that like to live in the skin normally. So what do we think of when we think of epithelial?
So we can think of follicular differentiation,
Good.
ductal differentiation.
When we think of ductal, what type of epithelium has ducts associated with it in the skin?
Are you talking like apocrine versus ecrine?
Ecrine, apocrine, and there's even one other one that has a duct associated with it.
I'm not sure other than those two.
Sebaceous, right?
Oh,
Sebaceous glands empty into the follicle. They have a little sebaceous duct there, So, so you don't really usually, if you get ductal, basically you see little small, round, tiny cysts throughout the lesion, like a syringoma, for example. But if you think of a ductal lesion, what was it, an ecrine sweat duct, an apocrine sweat duct, maybe a sebaceous gland duct, or what kind of epithelium is kind of at the bottom of that duct? So here, what do you think?
So I thought some of these looked ductal, like they kind of have a tubular structure, and like in that one to the left,
It might be like a duct here, but it's got the epithelial component around it, and these don't have any ducts, right? These are just little epithelial aggregates here. So do you think this is follicular?
It definitely could be. It was on my difference.
Possible. What others could it be? Could it be ecrine or apocrine?
Yes, it definitely could.
Okay, so how do you tell those apart from one another? Which one's more common to have a duct with it? Follicle or non-follicle?
Non-follicle.
Non-follicle, good. So if you see something with ductal differentiation, like here, there is a duct there, you should think quickly, probably apocrine or ecrine, most likely. Okay, so now we look at these cells, they look pretty round, small, cuboidal. They look like little clones of one another. What do we think of there? What kind of differentiation do we think of when we see the cells are round, basophilic, cuboidal, and they look like clones?
The poroid cells.
Good, poroid. So you're in the family of the poroid neoplasms now. So you've gotten it into that little category pretty quickly. So benign neoplasm, poroid differentiation. So what are the entities that are associated that give you the poroid differentiation?
Yeah, so the types of poroma, there's the ecrine poroma, hydroacanthoma simplex, the dermal duct tumor, and the nodular hydranoma.
Yeah, the poroid hydranoma. Good, that's it. Perfect. And then, of course, the malignant counterparts of those. So of those few, which one of these do you favor the most?
I think I would favor an ecrine poroma. There's a dermal component, and it looks like part that also connects to the epidermis.
Not this one area here, yeah. So they're not going to ask you, if they show you one on the board, they won't show you this. They'll show you one that's purely in the dermis. But if you get into the poroid category, you've made an A. you're good. You're good that you've done that. This we thought was more of a dermal duct tumor. Usually when you see a poroma, it's like the whole epidermis is acanthotic dramatically with the poroid cells in it, not just one little tiny area. So the bulk of this is in the dermis. So it just kind of happened to still be connected to the epidermis, this one little area. But this was an example of a dermal duct tumor. But anyway, and we don't see those very frequently, so that's why we put it in here for you. But basically, if you got it into the poroid category like you did, and you recognize that there was evidence of ductal differentiation, but also the more epithelial differentiation over here, and that these were cuboidal, monoclonal kind of appearing cells, you actually did well on it. So that's great. Good. Any questions about this one?
No, thank you.
Okay, good. Okay. All right, I got another one here for you guys. This is kind of sneaky, but they probably won't do this to you on the board, but still, we'll put it in here for you. You'll be ahead of your colleagues.
Good morning, Dr. Cockerell. My name's Yelena. I'll take this case. Looks like we have a shave going on, and I was favoring an inflammatory process for this one.
Good, excellent.
And then starting kind of from the top, we can go ahead and see the stratum corneum looks a little bit kind of flaky and like it's coming off. Perhaps there's a little blister within the stratum corneum, and it looks like there's collections of neutrophils.
Okay, good. What about the inflammatory infiltrating the dermis?
Yes, so in the dermis, it looks like there's some lymphocytes scattered around as well. A little bit of eos potentially, and some.
Good. Excellent. Eosinophils.
Mhm.
Okay, so we're going to be, let's play the game of you're writing the board question, and what kind of things are you going to put in the differential diagnosis here?
So there's a lot of things that could potentially be in the subcorneal, like neutrophilic pustule differential. Things could be bullous impetigo, where we would see like gram-positive cocci towards the top. We could also think about maybe tinea, and we would do like a PAS stain to rule that out, AJEP. But we'd expect to see some like papillary dermal edema with the AJEP. There could be some EOs in that one. Pustular.
Tinea, with that, if you were so you notice the eosinophils here, and you said, well, gosh, you know, tinea is in there, bullous impetigo. Do you get eosinophils in those conditions?
Mm-hmm. You're saying there are or aren't?
Well, we did see a few in here. I agree with you. But if you start looking at that, and then you start looking down at your answer choices, and you see eosinophils, and you say, gosh, I saw some eosinophils in there.
Mhm.
You know, tinea, bullous impetigo, psoriasis, AJEP, those things are all in the differential.
Yeah.
Is that going to throw you off?
I think you
Possible choices here.
typically wouldn't see the EOs in those, like tinea or bullous impetigo.
Well, believe it or not, anytime you get any kind of infectious disease, you can sometimes get some eosinophils in there. And so you do see it in tinea, actually, surprisingly. So that's just one thing. That's why I mentioned it to you. I don't want to let that throw you off. So if you see 5 criteria for one diagnosis and one thing that sort of doesn't seem to fit perfectly, don't place too much emphasis on that one thing. Okay. So if you see this sandwich sign, normal vascularly cornified layer with parakeratosis and neutrophils in the sandwichy area there, you should surely think about these entities that you're mentioning. Definitely should think about a fungal infection, more so than psoriasis. Psoriasis usually doesn't give you an AJEP. They usually don't give you the sandwich sign like this. So this has got a nice example of that finding here. And when you see that, that really should make you think of a fungal infection here. And I don't know if you guys were able to go back and see this, but even though we didn't give you a PAS stain, there are hyphal elements in here that you can see on the actual slide if you really look at it carefully. So whenever you see this sandwich sign, parakeratosis with neutrophils and the cornified layer, this basket weave overlying it, the hyphae love to live in that little interface right there. That's where they like to live. So you can see that with H&E in many cases without even needing a PAS stain. So we didn't, so this is an example of a fungal infection. But those are the kind of things that they're going to put on the exam for you. And I would say that if you're trying to differentiate between, and I don't know that they would be that tricky where they would say, fungus without a PAS stain and ask you to differentiate that from psoriasis or AGEP or even bullous impetigo. That's kind of unfair. So I don't think you're going to get that. But the main teaching point here is the sandwich sign and the fact that you can sometimes see eosinophils in dermatophytosis. It doesn't mean that it's not that. I've seen some cases of tinea with lots of eos in it. So just remember that. And there's a lot of different patterns of dermatophytosis. Can you name a few other histologic patterns that we can see other than this pattern? Would probably just be tinea, infection. This be just maybe tinea corporis. It looks like it's on the trunk here, or maybe the lower leg, because there's some stasis alter findings here.
Are you thinking along the lines of like a bullous tinea?
Good. Bullous dermatophytosis, absolutely. You can get lots of spongiosis, lots of papillodermal edema. Can simulate a bullous process. We get cases every now and then of rulate pemphigoid. It turns out to be bullous tinea. So that's one. What are a couple of other patterns?
There's also ulcerative, I think.
You can see ulcerative tinea in some cases. Yeah, it's sort of less common. But what are some more common patterns of dermatophytosis?
I guess one could be like a normal skin variant where not much is going on.
Well, yeah, we do see that where it looks normal and lo and behold is positive with a PAS stain. But what are some more common ones that you see in the clinic? Like, especially if you're dealing with peds clinic, the peds derm clinic, what do those kids very commonly have on their scalp?
Oh, like a tinea capitis.
Yeah, tinea capitis. And then what about a younger woman that shaves her legs and they come in and they get a fungal infection on their lower leg? What's that called sometimes?
Are you,
Goes down into the hair follicles of their leg. What do you call that?
the Mycosis
Yeah, Mycosis granuloma. Good, where it's just involving the hair shaft. And those often you have to really find the infected hair shaft. If you just do a PAS stain of the epidermis, it may be negative. And unless you actually get that hair shaft, you can miss the diagnosis. And then sometimes we get an unusual dystrophic, dysmorphic tinea infection in immunocompromised patients. I've seen a case a few years ago that actually looked like blastomycosis because the organism actually kind of started growing in the dermis. So there's a lot of different patterns of tinea infection. So just make sure you're well aware of those. So that's good. That's basically what you were supposed to see here. All right, we'll shift gears to this fun lesion here.
Okay, I'll take this one. So it looks like we have a shave, and I'm going with neoplastic.
Good.
And so I would say this is possibly malignant because it's very large and deep.
Yeah. So possibly.
Most likely, very likely malignant.
99% sure. It's got all the features of malignancy low magnification. Look how asymmetrical this thing is. And it's broad. It's interesting that you can kind of almost draw a line around it, but it's not really super well circumscribed. It's kind of cells are beginning to intercalate between the collagen bundles over here. So yeah, this ain't good for the patient. So malignant. At low magnification, you like epithelial, non-epithelial, not sure. This is an artifact here, but
Got it. I was leaning towards epithelial.
okay, good. Well, let's go to higher magnification and let's see if we can tell what type of epithelium. I'm a little different animal here than we were before, aren't we?
Yes. So lots of blue cells in the dermis.
Good.
And so I was leaning towards possibly like Merkel cell because of the appearance of these blue cells almost smushed together.
Yeah, I agree. I mean, these cells have kind of this indistinct chromatin. What's one other potential item in the differential diagnosis? So kind of looking at some of these kind of whitish clear areas that you might think about.
Well, you would have small cell carcinoma of the lung on the differential.
But notice, this is a
That-
little bit curious for Merkel here. I think some of this is probably an artifact. But what else should you at least think about when you see bubbly cells plus basophilic cells in the skin?
Something, a sebaceous carcinoma.
Good. Sebaceous is what I was trying to get you to read my mind about there. So, so you think about sebaceous. We'll look over some of these other areas, and I think we can kind of see, yeah, this really kind of looks more like the smudgy, indistinct chromatin that we might see more with a neuroendocrine carcinoma. Good. So, and here's actually what phenomenon are we looking at here?
Not sure.
See the endothelial cells here?
Oh, yes.
Blood vessel. So that's actually a sign that the neoplastic cells has gone inside a blood vessel here. That's
Oh,
not a good thing. It could either be the tumor going into the blood vessel and going to spread throughout the body, or possibly that's coming secondarily. So this was a neuroendocrine carcinoma here. I believe this was a primary Merkel cell in this case. But what's in the differential diagnosis of primary Merkel cell carcinoma?
so small cell carcinoma of the lung.
Yes, that is metastasized to the skin. And there's one marker that we use to kind of help distinguish that. Do you know what marker is more commonly seen in the metastatic small cell carcinoma than in primary Merkel cell carcinoma?
Is that TTF1?
Yeah, thyroid transcription factor 1 is the one that we see there. And the other stains that we use for this are things like cytokeratin 20, and you get the characteristic paranuclear dot staining pattern. You can sometimes even see a little pinkish structure that's actually represents that if you really look carefully. I'm not sure we see too much of that here, but that's kind of what those look like. Synaptophysin, things like INSM1, those are the markers that we use to actually make this diagnosis. And the other thing about this entity too, it used to be called trabecular carcinoma. You can see these little fibrous strands between the aggregations of the neoplasm here. That's also characteristic of this type of tumor versus, say, a sebaceous carcinoma. You usually see that in the sebaceous carcinoma. So the kind of the confounding element of this is it's got these cells that kind of almost look quasi-sebaceous in some way, but this is an example of a Merkel cell tumor. Now, just sort of as a bonus question, again, I don't know that you'll get this on the board, but it's possible. What are some other small blue cell tumors that are in the differential diagnosis of this? We said sebaceous is one. What are 3 or 4 other tumors that you have to distinguish between or among when you're looking at a lesion like this?
So think about basal cell carcinomas as well.
There is a type of poorly differentiated metatypical basal cell that can kind of simulate Merkel cell on occasion. Yeah, that's one thing you have to think about.
What about melanoma too?
Melanoma, it looks like just about anything. So yeah, you definitely want to rule that out. What about if we just said it's in the category of the small blue cell tumors?
Yes. So there's the whole differential for those. Like I said, the oat cell tumor, which I believe is the lung.
So those are, yeah, that. Well, what other ones are in that category? Shift gears into the pediatric world.
Okay. We have I'm trying to think. Neuroblastoma, is that also
Good.
one?
Yes, neuroblastoma, Wilms tumor, Ewing's sarcoma. Those tumors give you this blue cell morphology. Carcinoid tumor, blue cell morphology. Poorly differentiated anaplastic lymphoma is in the differential diagnosis here. So when we get one of these lesions, obviously we ask ourselves, what's the setting? Is it a child, is it an adult? And then probably the one other thing that the board might ask you if they showed you this and said this lesion was positive cytokeratin 20 and Mycosis or endocrine carcinoma, what is one potential etiology of this tumor?
Oh, polyomavirus?
Good. Polyomavirus. So they sometimes that's like a maybe basic science kind of question. So they might ask you a second order question, expecting you to know that human polyomavirus has been associated with this tumor. Okay, good. So one last one.
Good morning, Dr. Cockerell. I'll be doing this one.
Okay, excellent.
We have a punch biopsy here.
Good.
From higher view, it looks like there's an infiltrate, in the upper layers of the dermis, trying to decide if it's neoplastic or inflammatory. I feel like it's kind of difficult at this power.
But do you think the cells in here are inflammatory cells, or you think they're neoplastic cells?
I think they're neoplastic cells.
All right, so what kind of cells do you think they are?
Well, I think they're atypical lymphocytes.
Ah, so
I know, so it's kind of a trick question.
so those are inflammatory cells gone bad, right?
Yes, correct.
So we'd say it looks like it's a process with inflammatory cells. Now, okay, so you thought they were atypical lymphocytes, but before we go to higher magnification here, do they look atypical with this power to you?
No, they don't.
They don't. But is there anything about the pattern?
It's
Might help you?
it's an interface pattern. You can kind of see it budding up into the epidermis.
Okay, so overall, when you see this kind of, notice the papillary dermis is pretty full of cells, right? It's not like chock full of cells like in planus.
Uh-huh.
But it's kind of got a band-like infiltrate is what we call this, and it's kind of patchy. We also talk about this. So like, think about a patchwork of quilts, if you will. Here's a little piece of cloth that they sewed together, and here's another one, and another one, and another one, and another one. So basically, it's kind of what we call patchy infiltrate. It's not dense lichenoid. And when we see that at low magnification, when it's fairly dense infiltrate like this, and then we see this involvement of the epidermis, yeah, that should make you think, uh-oh, this might be Mycosis fungoides. So, and that's what this is, right?
Yes.
Okay, so you can make that diagnosis at low power, at least suspect it at low power, without even really looking at the morphology of the lymphocytes. And I can tell you a lot of times you start looking at the actual lymphocytes themselves, they don't really look super atypical. I don't really see any, Sézary cells here or any large cerebriform cells. I mean, they're hyperchromatic, but lymphocytes are hyperchromatic. So if you base your diagnosis, if you wait to diagnose MF until you get protease collections with lots of large floret-like lymphocytes, you're waiting too long.
Yes.
In my opinion.
Yes.
So based on this, we diagnosed Mycosis fungoides. I just diagnosed the case 30 minutes ago. And I diagnosed it without doing a lot of stains or markers or anything. When I see this pattern and it's got the thick collagen and like here, and it's got the cells in the epidermis, and notice that you've got a disproportionate number of lymphocytes in the epidermis versus spongiosis.
Yes.
And you've got these single cells lining up at the basal cell layer also, like an eyeliner sign. To me, you diagnose this as Mycosis fungoides and you start the patient on therapy. Get them with an Arabin UV or topical nitrogen or whatever you're going to use to treat them. Don't wait until they get this. Now, if you don't feel like you can make the diagnosis, well, then you can send it off for gene rearrangement studies. 35% of the time, that's going to be wrong. Okay, in a thin lesion of early MF. This one, it might come back as positive because it's got quite a few cells here. But if it's got, a few cells in an early patch stage lesion, it doesn't always help you. So you have to be able to recognize this pattern and then also put it in the context of the clinical appearance. But this is really, I'm glad you recognize this as MF, but just notice some of the the cells really aren't super atypical.
Yeah.
So, that's the whole thing. If you kind of have to have a real high threshold for cytologic atypia and whatnot, you're going to miss the diagnosis or you're going to delay the diagnosis longer than it necessarily needs to be. And I'd rather take a patient like this when they've got an early curable stage of the disease and put them on a relatively innocuous therapy than to keep calling it, non-specific dermatitis or spongiotic dermatitis or whatever and let it go and go and go until they finally start getting some plaques. And then it's too late or it's much harder to treat. Now we've got the diagnosis here, so we've got our answer. So we've got 5 minutes left. So you've got to figure out a way to tap your brain a little bit further. So what else is in the differential diagnosis here of this? So we look down at our multiple choice list, and what are some things in there that might look like MF, but really is not MF?
Well, so you already kind of mentioned one, like the eczema. If it was not as, if there weren't as many lymphocytes and there was more spongiosis.
Yeah, but that was too easy.
Yes.
We don't want to, we want to really trip up our colleagues here. We want to make it a really, really tough question. So we're not going to put atopic dermatitis down. We're going to put some other things that really can look very, very similar to MF.
There's like the slack skin.
Well, tell me about granulomatous slack skin. What is that entity?
Isn't it a variant of MF of some
Yeah,
sort?
yeah. So that wouldn't be a good answer because that really is MF in a way. It's MF that gets a granulomatous inflammatory response to it. It starts engulfing elastic fibers. They get these pendulous folds of atrophic skin. They get these large multinucleated histiocytes that engulf the atypical lymphocytes. So it's kind of a host response. It's a variant of granulomatous, quote, mycosis fungoides, which is basically, we think, the host response coming in trying to fight off the MF. But there's some other things that look histologically identical to MF, or very close to MF histologically.
There's the LYP.
Yes. There's a variant of lymphomatoid papulosis, and I've sort of sworn an oath not to memorize the multiple subtypes. I think it might be the B subtype or whatever, but it can look very, very much like MF histologically. It gives you it looks just like this, but it's got CD30 positivity. Of course, you get CD30 positive transformation in MF too, so you have to differentiate those clinically, papules versus plaques and patches. So that's one. Yeah, good. What are some others that can look very much like MF?
Other types of lymphomas, like a T-cell lymphoma.
The B cell pattern, though, not usually. And you say, okay, if you want to say other lymphomas that can look like MF, like the HTLV1 associated lymphoma, that basically looks very, very much histological like MF, but it's got those large floret cells. You get the leukemia associated with that. But so that could be, but that really would be almost like it sort of is MF. But there's some non-MF entities, like you mentioned, lymphomatoid papulosis, that can look very, very much like MF, that you just at least should know about briefly. They wouldn't expect you to recognize that on the board unless you showed you a clinical photograph. What if I told you this came from the back of the neck of a, say, 55-year-old guy that had worked out in the sun, and every time he went out in the sun, he got a horrible reaction, mainly in the sun-exposed areas. And biopsy, it looked like this, and it had been going on for 30 years.
Like the rhomboid Nepal, oh my gosh.
Actually, chronic actinic dermatitis, chronic photodermatitis can look just like mycosis fungoides. And a couple other things that can simulate MF, pityriasis lichenoides, also, that can look a lot like mycosis fungoides. And then some, variants of mycosis fungoides, like drug eruptions. Drugs can do anything. Lymphomatoid drug eruptions, but those are the main things. So remember LYP, which you're right about that. Remember chronic actinic dermatitis can look like this, and then the HTLV1, that's a variant of MF, if you will, another other type of CTCL, and then some of the pityriasis lichenoides diseases can simulate MF sometimes. So good. We went through all of them. We conquered the mountaintop here. So you guys are hopefully getting ready for your boards coming up in a few months. So any questions about anything we did today? If not, we'll say goodbye and we'll see you guys next month.
Thank you.
You're welcome. Take care.